This talk will be on the Sella and parasellar region. First, I'll cover the anatomy and physiology, then congenital lesions, vascular and ischemic lesions, inflammatory lesions, and finally tumors and cysts. So first, anatomy and physiology. The pituitary has two components, the anterior pituitary or adenohypophysis, which is in purple, and that has three components. The pars tuberalis is a very small portion of it that is on the pituitary stalk. The pars intermedia is, I believe, present in fetal life, but it involutes by adulthood, and it's the area between the anterior and posterior pituitary. It's kind of the boundary between the anterior and posterior pituitary, and I think basically this is just the source of pars intermedia or Rathke cleft cysts. And then finally the pars distalis, which is the bulk of the anterior pituitary. It's all this other stuff. The main part of it is the pars distalis. The neurohypophysis or posterior pituitary has the pars nervosa back here in beige, and the infundibular stalk, which is neural tissue, which are actually axons that go from the hypothalamus down into the posterior pituitary. Okay, the blood supply. The adenohypophysis gets most of its blood supply through the portal venous system. That's the hypothalamo-hypophyseal portal venous system, and only a small component directly from the internal carotid. The neurohypophysis gets its blood flow directly from the superior and inferior hypophyseal arteries, which are small branches of the internal carotid. So function, the adenohypophysis produces these 5 hormones. Prolactin and growth hormone I have in orange, and that's because the cells that produce the prolactin and growth hormone are located more laterally within the pituitary gland, so I have those on the sides. The cells that produce ACTH tend to be more centrally. So when you see a prolactinoma or growth hormone producing adenoma, they tend to be in the lateral aspect of the pituitary, whereas the Cushing's adenomas tend to be more in the middle. Neurohypophysis stores oxytocin and ADH. The bright signal of the posterior pituitary is due to ADH storage. So it's not produced in the posterior pituitary, it's produced in the hypothalamus and travels down the pituitary stalk, and it's stored in the posterior pituitary. And the storage granules for the ADH are T1 bright. Okay, this is asymptomatic 15-year-old girl. Pituitary gland looks a little bit big, but it's quite symmetric. It's homogeneously enhanced. And this is physiologic pituitary hyperplasia. It's often seen in adolescent girls, and also we see it often in pregnant and postpartum women. You can also get hyperplasia of the pituitary secondary to end organ failure. So in severe hypothyroidism, the pituitary gland tries to compensate by pumping out extra TSH, so you can get enlargement of the pituitary on that basis. But typically with pituitary hyperplasia, the gland is symmetric and uniformly enhanced. These are 2 asymptomatic patients. The Sella is filled mostly with CSF. So these are patients with empty Sella. Some people call it empty Sella. Some people say partially empty Sella because there's generally some pituitary tissue in there. The CSF pulsations gradually enlarge the Sella. We see this sometimes associated with intracranial hypertension, pseudotumor cerebri. So if we see an empty Sella in a young woman, we think about pseudotumor cerebri. If we see it in an older patient, it's generally just an incidental finding. Occasionally you can see it secondary to pituitary necrosis or prior tumor treatment. Generally, the patients with empty sella do not have any endocrine dysfunction, so the small amount of pituitary tissue that's plastered along the bottom of the sella is usually functionally normal. Differential here would be an arachnoid cyst. An arachnoid cyst would displace the pituitary stalk, whereas with an empty sella, the pituitary stalk just goes straight down to the pituitary gland. Congenital abnormalities. This patient, the two slides on the left are before contrast, the one on the right is after contrast. The pituitary gland itself is quite small. We can hardly see any pituitary stalk. I don't see any. It should be over here, but I don't really see anything. There is some enhancement up here on the tuberosnarium. So this is a patient with congenital hormone deficiency. So with congenital hormone deficiency, we look for a small anterior pituitary, a smaller absent pituitary stalk, and we'll often see ectopic posterior pituitary. So in this case, you can see this hyperintense posterior pituitary is located at the tuberosnarium or top of the infundibular stalk. So since the pituitary stalk is not formed or is abnormal, the ADH cannot travel down to its normal position in the posterior pituitary, and you get this ectopic posterior pituitary bright spot. The patients who have multiple hormone deficiencies tend to have a more severe abnormality. So the patient on the left with multiple hormone deficiencies, you can't see any pituitary stalk. The gland is really small. The one on the right just has growth hormone deficiency. And you can see like there's a little bit of a pituitary stalk here. The gland is still fairly small. Vascular and ischemic lesions, we'll look at pituitary apoplexy, Sheehan syndrome, and aneurysm. So 50-year-old man, acute onset of headache and visual impairment, and we see an enlarged pituitary gland with a large hypoenhancing area centrally. So this is the typical appearance for pituitary apoplexy. So this is either acute hemorrhage or infarction, and it usually occurs in a pre-existing macroadenoma. So the patient usually has a macroadenoma and then infarcts or hemorrhages into it and presents with acute headache, often visual problems because the hemorrhage causes acute enlargement of the gland. This is a younger patient with a postpartum headache. We did a MRA. Initially, we thought there was an aneurysm over here. So on further evaluation, if we look carefully at this area, we look at it on the source images, you can see there's actually a fluid level here with bright signal on top and dark signal on the bottom, and this is due to hemorrhage into the pituitary gland. Here's the coronal images. You can see this had hemorrhage into the right side of the pituitary gland here. And post-contrast, the hemorrhagic area does not enhance with contrast. So this is a patient with Sheehan syndrome, infarction of the pituitary due to pregnancy-induced hyperplasia. And typically you see it in patients with complicated delivery where there's hypotension and shock, and then you get infarction of this hyperplastic pituitary gland. Here we can see a T1 hypointense lesion involving the left side of the sella. When we see this markedly T1 hypointense structure, first thing we should think about is an aneurysm. The aneurysms involving the sella can either be cavernous or supraclinoid aneurysms. This is a cavernous aneurysm. Look for the flow void. Sometimes you'll see ghosting artifact. I think you can see it here. You can see kind of faint ghosting artifact in the phase encoding direction from the flow through this aneurysm. They can have a very funny appearance. They're often partially thrombosed. They can confuse you, and you want to try to avoid confusing this because obviously aneurysm is treated a lot differently than tumors. Here's another patient with a cavernous aneurysm on the right. Here it's bulging out the cavernous sinus. And it can be tough because this one does not have much of a flow void. You can see the signal in it is kind of funny. It has some darker signal. Some darker signal here and then some brighter signal more laterally because there is some flow in it. This is the angiogram, and you can see that the aneurysm on the angiogram is much smaller than the aneurysm on the MRI because the bulk of the aneurysm is thrombosed. So these are often partially thrombosed. It's another aneurysm. This one shows a funny lamellar kind of appearance. Yeah, when you see this laminated appearance, yeah, think aneurysm. That's from clots of different ages causing that laminated or lamellated appearance. Another patient with an aneurysm, mixed signal on T2, some dark, some light because it has some flow and maybe some thrombus in it. Post-contrast, yeah, here this one you can see partly fills with contrast, so it can easily be confused with an adenoma. Here's the angiogram showing this lobulated cavernous aneurysm. Let's move on to inflammatory lesions. We'll talk about abscess, sarcoid, and autoimmune hypophysitis. Pituitary abscess is very uncommon. This is a patient with a hypoenhancing lesion within the pituitary gland. This one kind of looks like an adenoma, but it looks very cystic or necrotic. It can be a hematogenous infection or spread from adjacent sphenoid sinus, but it's quite an uncommon entity. This patient has some enhancement more in the suprasellar region, and maybe a little bit of enhancement even going along the ependym of the third ventricle. Here it is on the sagittal post-contrast image. And this is a patient with sarcoid. So sarcoid can cause either leptomeningeal, dural, or parenchymal enhancing lesions. You may see a single lesion, more often multiple lesions. And CNS involvement occurs in about 10% of patients with sarcoidosis. However, it's often the presenting manifestation, so the patient may not have a history of sarcoidosis when they present with neurosarcoid. Now, the patient with neurosarcoid, for some reason, the suprasellar region is a very common site of involvement. This one may be some subtle areas along the ventricles too here. This is a young woman, a postpartum headache, is a non-contrast MRI. The pituitary gland is enlarged here, extends into the suprasellar region. Looks like it's maybe pushing on the optic chiasm a little bit there. And this patient, this is a post-contrast. You can see it actually enhances fairly uniformly with the contrast. Yeah, this patient had a second trimester ultrasound for migraine, which showed a normal-sized pituitary gland. So this seems to have come up fairly recently. The patient was given steroids 4 days later. The enhancement is the same, but the pituitary gland is much smaller. Looks like there's like a little cystic area that's in it that was unchanged, but the gland is much smaller. So the steroids were stopped, and follow up 1 month later, and the gland is big again. And then they put this patient on steroids, and a few days later it's small again. And then 4 months later it stayed small. So this is a patient with autoimmune or lymphocytic hypophysitis. So the two situations you typically see this are peripartum is probably most common, and secondly we see it on patients who are on certain immunotherapies. They often present with hormonal deficiency, so the gland, although enlarged, tends to be functionally not working very well. It can involve the pituitary gland or the stalk or both. It can be either homogeneous or heterogeneous enhancement. And the differential here is pituitary hyperplasia, macroadenoma, or pituitary metastasis. This is a patient with melanoma, baseline scan here, pre and post contrast, and then a 6-month follow-up after the patient was put on immunotherapy, and now we can see the pituitary gland is enlarged here, somewhat heterogeneously enhancing. Initially we thought this was a metastasis to the pituitary, but they continued the immunotherapy, and the patient became hypopituitary, and they required hormone replacement. But 6 months later, you can see there's a small pituitary gland, no longer enlarged, and this is another patient with hypophysitis, in this case due to immunotherapy. The last segment is going to be tumors and cysts. We'll talk about pituitary adenoma, craniopharyngioma, Rathke cleft cyst, meningioma, metastasis, chordoma, germinoma, hypothalamic glioma, and tumor cinereum hamartoma. So first, a patient with a large sellar and suprasellar mass markedly expands the sella here. Looks like a bunny rabbit on the coronal images. And this is pituitary macroadenoma. So macro basically just means more than 1 centimeter, micro less than 1 centimeter. The adenomas can be functioning or non-functioning. The functioning adenomas produce either prolactin, growth hormone, or ACTH. The non-functioning adenomas tend to present much later, since they don't cause any hormonal symptoms. They don't present until they cause symptoms like visual issues. When we look for a microadenoma, sometimes dynamic imaging can be helpful, so we get very fast images, say every 30 seconds or so, because sometimes this will enable us to see a microadenoma a little bit better. The normal pituitary gland will generally enhance before the microadenoma, so this is the pre-contrast on the left, early post-contrast, and since the pituitary gland is supplied mainly through the pituitary stalk by the portal venous system, we'll first see enhancement in the pituitary stalk and the top part of the gland, and then on the later image on the right, the contrast will pass through the entire pituitary gland. So most of the time it's not that helpful. Occasionally we'll see a microadenoma a little bit better on the dynamic images. So this is one case. This is a delayed image, and you can see there is a microadenoma here on the right side of the gland, but it's kind of a subtle thing. On the early dynamic image, it's a little bit better defined. So sometimes the contrast between the normal pituitary gland and the adenoma is a little bit better on the dynamic images. The downside of the dynamic images is that the resolution is lower, because we do them pretty quickly. This is just to show if you can't do an MRI, you can evaluate the pituitary on CT. This is a patient with a microadenoma that we diagnosed on CT here. Typical pituitary adenoma, sort of a snowman appearance with a widened portion within the sella and then another widened portion in the suprasellar region. One thing we can look at with the adenomas is to see if it involves the cavernous sinus, and we diagnose cavernous sinus invasion if we can see the tumor going lateral to the cavernous carotid. The pituitary adenomas most often grow up into the suprasellar region, but sometimes they just grow down. In this case, the tumor grew into the clivus here, so this is adenoma growing into the clivus. You can see it on the CT with this bone, loss of bone in the clivus. One helpful thing, very key point with the pituitary adenoma, since it starts in the sella, you'll almost always see expansion of the sella here. So you see expansion of the sella, you're almost always dealing with a pituitary adenoma. And regardless of whether they destroy the bone or anything else, they're almost all benign. There are hardly any pituitary carcinomas. Occasionally you'll see hemorrhage into an adenoma. So this is a pituitary adenoma with T1 hypointense hemorrhage. That's a non-contrast T1. The one on the right is post-contrast. Actually, the adenoma is bigger. It's this whole thing here. But the hemorrhagic portion is just this part over here. Okay, so the patient has a suprasellar mass. Pre-contrast on the left, post-contrast on the right, so it's heterogeneously enhancing. It's sitting on top of a fairly normal-appearing pituitary gland. This is a fairly young patient, and this is a craniopharyngioma. So this is generally suprasellar lesion. About a quarter of them also have an intracellular component, most often in children, but there is a second peak in middle age, 50 to 60 years old. There are two types of craniopharyngiomas. The most common is the adamantinomatous, and this is the classic type with an enhancing component, a cystic component, and calcification. The less common type is called papillary. Usually that's seen in the older patients, and it tends to be a more solid, less cystic appearing tumor. But the appearance overlaps, so even the papillary ones can have cystic components also. But the majority are adamantinomatous. Another patient with a pituitary adenoma, so mostly a cystic mass with heterogeneous enhancement along the rim here. Again, notice a normal pituitary gland, so that helps you diagnosing a pituitary. This helps you distinguish it from pituitary adenoma. The cystic components of the craniopharyngiomas can have various types of material in them. At surgery, it's often a thick type of material. On T1 weighted images, the cysts are often T1 bright and T2 dark, but the material can vary. But if you see this T1 bright, T2 dark material, that's fairly common with a craniopharyngioma. CT can sometimes be helpful because most of these have calcification. So this one, we can see the calcification here on the CT. So sometimes that can help differentiate it from a pituitary adenoma, since adenomas do not commonly have calcification. But the most helpful thing, of course, is that the pituitary adenomas will expand the sella, whereas a craniopharyngioma generally will not, because it starts in the suprasellar region. So here we have a non-enhancing lesion in the sella and suprasellar region. And this is a Rathke cleft cyst. So 40% of the time these are completely within the sella. 60% of the time they're both intracellular and supracellular. And they can have any variety of signals. So on T1 it can be bright or dark. On T2 it can be bright or dark. And of course the important thing here is that it does not enhance with contrast. It's another Rathke cleft cyst, T1 bright in this case, a funny shape to it. It's another suprasellar mass. You can see the mass over here. fairly homogeneously enhancing with contrast. And you can see a normal appearing pituitary gland at the bottom. On the sagittal image, pre and post contrast, this one you can see a nice dural tail here. So this is a meningioma. This one looks like it arose from the tuberculum sella. They can arise from the clinoid, the sphenoid wing, cavernous sinus. The meningiomas often involve the cavernous sinus, and they frequently narrow the internal carotid artery. So when a pituitary adenoma extends into the cavernous sinus, it can go around the carotid, but it won't narrow the carotid. But meningiomas involving the cavernous sinus, not always, but frequently will narrow the internal carotid artery. And if you see a dural tail, that's very helpful, of course. Patient with a history of breast cancer, pre and post contrast images, see an enhancing mass. In this case, it's mostly in the pituitary stalk and hypothalamus, partly in the pituitary gland itself. So this is metastasis. So metastases, most commonly breast, lung, melanoma, but pretty much anything can do it. You can have hematogenous metastasis, again, either to the gland or the stalk. Or sometimes you can have direct extension from a bone metastasis or spread along the CSF to the pituitary. So another this is a patient with breast cancer with a metastasis to the pituitary. Looks like this one, there's also a bone metastasis here involving the clivus. It's kind of dark on T1. So this is metastasis to the pituitary gland. This one is a patient with melanoma with a nice heart-shaped metastasis pituitary stalk. This patient has a mass involving the clivus, pre and post contrast, T1, heterogeneously enhancing lesion in the clivus. On T2, it's quite T2 bright here. It has some septations within it. This is a chordoma, so these arise from notochord remnants. 50% in the sacrum, 35% in the clivus, and about 15% in the vertebrae. These often have calcifications, and a very helpful sign is very high signal on T2 weighted images, and it has a low signal capsule and some internal septations. Young patient, pre and post contrast CT. So suprasellar region, hyperdense on non-contrast CT, enhances homogeneously with contrast. Here's the MR, post-contrast MR on this patient, showing this enhancing suprasellar mass, a young child. And this is a germinoma. So we typically see them in children and young adults. They occur either in the suprasellar or the pineal region. For some reason, the suprasellar germinomas are about equally distributed between boys and girls. The pineal germinomas are much more common in males. So, and I have no idea why, but pineal germinomas, I think it's about 10 to 1 male to female. Suprasellar germinomas, about equal male and female. Typically have homogeneously enhanced contrast. These frequently spread along the CSF, so we often need to evaluate the entire spine to look for spread. They often present with diabetes insipidus, so that's a very early clinical finding, is diabetes insipidus, and they're very sensitive to radiation. If you see a lesion both in the suprasellar region and in the pineal region, almost always we're dealing with the germinoma. I don't know if this is two germinomas separately or one metastatic to the other, but if you see both suprasellar and pineal enhancing masses, that's almost always going to be germinoma. Another patient with a suprasellar mass, pre and post contrast T1 and T2. Initially we thought this might be an aneurysm here, but the MR angiogram was normal. Here's the sagittal and coronal images of the Sella. We can see that there's some central enhancement within this suprasellar mass. And if we look carefully, we can see the mass is contiguous with the optic chiasm here. So this is actually arising from the chiasm or optic nerve, and this is a chiasmatic glioma. So chiasmatic or hypothalamic glioma. Children, young adults, it's often associated with NF1. About half of them enhance with contrast, and occasionally these can extend into the brain along the optic radiations. And the final lesion we'll talk about, this is pre and post contrast T1. We see a mass in the suprasellar region here. It does not enhance with contrast. T2, it's a similar signal to the brain on T2. And this is a tuberostinarium hamartoma. This is a particularly big one. Most of them are smaller. The classic presentation is precocious puberty and gelastic seizures. The signal is similar to brain tissue. Does not enhance with contrast, so tuberostinarium hamartoma. All right, thanks for your attention.